Hello. So I am doing some recording today, and I'm recording some information about male reproductive organ problem. I'm going to share my screen so you are seeing what I am talking about. And we will be specifically talking about prostate disorders and testicular and scrotal disorders. So prostate disorders include benign prostatic hyperplasia, otherwise known as BPH, and prostate cancer. And testicular and scrotal disorders will include testicular cancer and orchitis. So non-cancerous male problems. Benign prostatic hyperplasia, BPH. So every person born with male reproductive organs has a prostate, and it is a gland that surrounds the urethra. And so what happens is that prostate gland can actually grow, and it can grow big enough that it will actually narrow the urethra and perhaps even shut it down. It causes difficulty starting the stream of urine, weaker flow, it causes urinary frequency, and it can cause incontinence, and it can be really, really painful. Orchitis is a different problem. So orchitis is inflammation of the scrotum and the testes. So just some different vocabulary words that are associated with this particular problem. There's a hydrocele. A hydrocele is a non-tender fluid-filled mass due to altered lymph drainage. So there is like a fluid-y cyst in the scrotum. A spermatocele is a sperm-containing cyst, and it's firm, and it's also in the scrotum. A varicocele, or a varicocele rather, is dilation of the testes veins. So the veins of the testicles dilate, and they're called like unusual, abnormal dilation is called varicocele. Torsion is extremely painful. So I hear. Torsion is where the actual testis will spin in the scrotum and therefore twist the spermatic cord. It restricts blood flow to the testes and the epididymis. People who have a torsion of the testicle will throw up. They will have severe pain. They may need surgical intervention. All of these problems, whether it be BPH or an orchitis problem, involve physical examination and ultrasound for diagnosis. Excuse me. Oh, excuse me. Okay. So when it comes to BPH diagnostics, I just want to point out one little area here on the that color. So when I was talking earlier about the prostate, here is a cross section of the male reproductive organ anatomy. So the prostate is this thing that looks kind of like a flower leaf botanical thing. And see how there's the bladder, there is the urethra and ending over here. And so this prostate, if it gets enlarged, it compresses the urethra. And as it becomes enlarged, we can actually palpate it through the rectum. So what happens with a person who is going to their normal physical is they will have a history and a physical exam, right? And then they'll get what they call a digital rectal exam. And a digital rectal exam is where the client experiences palpation through the rectum in hope to be able to see if we can palpate the prostate here in the rectum or not. We are also looking for size, symmetry, and consistency of anything that is palpated in that area. Urinalysis, urine culture, and sensitivities can be drawn to be able to help determine if we have somebody who's got frequency and pain with urination, do they have a bladder infection or do they have a prostate problem? One of the ways that we can tell if it's a bladder infection or a prostate problem is to do a urinalysis to be able to see how that urine looks and what it consists of. The other thing that we can do for enlarged prostate gland is we can check their PSA level. A PSA is a prostate-specific antigen. We will also, if they're having, like I said, problems with urinary retention, and they're having problems with, we're trying to rule out bladder infection and see what's going on. If it, where is this problem? Is it a kidney problem? Is it a bladder problem? Is it a urethra problem? Is it an infection problem? So a serum creatinine and a renal ultrasound to be able to determine if there's a backflow of urine that may be causing kidney dysfunction would be appropriate. You may have a transrectal ultrasound of that area, where the ultrasound wand is inserted into the rectum to be able to take visual pictures and ultrasounds of the prostate gland. An MRI of the pelvis may be ordered. Uroflowmetry. I said that wrong. Uroflowmetry. That's where we're actually measuring the strength of the stream. So basically we're going to be asking our clients to void into a certain area, and we will measure the strength of the stream of urine that's coming out. Cystoscopy is where we actually are taking a scope up the urethra into the bladder to take a picture that way. We can also do urodynamic and pressure flow studies. The goals of care for BPH are to restore bladder drainage, to relieve the patient's symptoms, and to prevent or treat any complications of that BPH. So there are phases of therapy when we're working with people with BPH, including active surveillance. So active surveillance is where we're doing blood tests of that PSA, and we're doing digital rectal examinations, and we're repeating and checking post-voidal residuals if any symptoms change. But we're really just having them come in, do their yearly physicals, get a blood draw, and you have a digital rectal examination. Drug therapy, we may be having them do some finasteride, which is otherwise known as Proscar, some dutasteride, which is otherwise known as Avodart. Those are 5-alpha reductase inhibitors. They can do alpha adrenergic receptor blockers, tamsulosin. I gave a lot of Flomax. I gave a lot of finasteride as a nurse. Considering I'm a girl, I also, with the XX reproductive organs, I always wore gloves when I was administering those because of the nature of those drugs. There can be combination drugs that have both that 5A reductase inhibitor and an alpha-nergic receptor blocker. There can also be erectogenic drugs such as tadalafil, otherwise known as Cialis, to be able to help that problem as well. If it develops into a bigger problem and watchful waiting is not doing it anymore, there's two different ways that we can intervene, or that the team can intervene. There's minimal invasive therapy, and then there's invasive surgery. So a minimally invasive therapy is maybe like a laser enucleation of the prostate, or they can do a photoselective vaporization of that organ. They can do a prostatic urethral lift. They can do a transurethral microwave therapy. They can use a transurethral needle ablation. And then they can also do water vapor thermal therapy, all of those with the intention of killing off some of that prostate gland. So then the prostate gland is therefore smaller, and then the urethra has more room, and then the patient can pee better. If those aren't an option for whatever reason, maybe they were tried and it didn't work, or maybe things just advanced really fast, the client can go under a few different forms of therapy. They can get what's called a transurethral incision of the prostate. An incision is where they will use the urethra as an entry point and remove some of that prostate tissue. They can do a transurethral resection of the prostate where they actually take a lot of that tissue, or they could do a plain old prostatectomy where they just take it out. And that can be an open procedure where they're using the abdominal wall as the entry point. It can be a laparoscopic procedure where they use the gas and then blow up the abdomen just a little bit, and then they use robotics to be able to remove the prostate. And then there is robotic assisted prostatectomies for other entry points as well. So you can either have it open in the abdomen, laparoscopic, or maybe robotic assisted through that transurethral method as well. So I'm going to stop sharing here. And the next slideshow that I record will be nursing management of these types of problems.